I'm Mike Rosenberg. I'm one of the cardiologists here. Maybe we should wait another minute, given the weather. I'll start.
Traffic too.
Traffic bad too?
Yeah.
Okay. Well, just for you, I'm Mike Rosenberg, one of the interventional cardiologists here at Froedtert South. And we have a very exciting new opportunity to talk about that applies to many of us. Probably even more broadly than any of us would think. May I just ask, how many of you in the crowd have trouble with high blood pressure? And how many of you have had challenges with managing your blood pressure? And how many of you are on medicines that you don't particularly care to be on? Okay. So I'm glad that you're here because perhaps this will pique your interest. The new technology that we're going to be talking about is renal denervation. And the indications for the procedure are very broad, and the process is very new. So renal denervation, I'll give you a broad overview, and then we'll talk some more specifics. Renal denervation has been around for about 10 years. It has been in an investigation. There are two companies in the space. And it has been on again, off again in terms of results, and now on. So the FDA has approved it as of November of 2023, commercially available since very early in 2024. Very few centers have adopted it yet, but there's a lot of buzz about beginning to do that. We are the only center in Wisconsin, and I'm not sure how many in Illinois. I think maybe the only one in Wisconsin and Illinois doing this. So it's exciting, and we've done about 20 patients. So let's talk a little bit about this. This is a depiction of the kidneys. Let's see if this doesn't really work on the screen. Okay, so kidneys, aorta, and along the kidneys you see there's an artery that supplies each kidney, and then there are what look like little tentacles that come around those arteries and hit the kidney, and those are the renal nerves, which is going to be the focal point of what we're going to be talking about. So this slide is incorrect, but hypertension remains the leading global cause of death and disability. I'm sure you understand that. Coronary artery disease, stroke, aortic aneurysms, all these things stem from longstanding high blood pressure, and control of blood pressure is key, fundamentally key, to retarding the rate at which these problems progress. So if any of you have those things as issues, please understand that this problem, hypertension that is poorly controlled, if remedied, can impact those issues as well. So blood pressure is, of course, they say the silent killer. It is indeed, that's true. And although what I wrote here is that 50% of the hypertensives in the US fail to reach blood pressure target, I think more people than not think it's closer to 75% of people do not reach the blood pressure target. Oftentimes your doctor will say, it's okay, it's good enough. You may say, it's okay, it's good enough. Why do you say that? Because you don't want to be on more medication. You're already on enough, and you don't like what you're taking in the first place. So many of the issues in terms of blood pressure control are patient non-adherence, so people not taking their medications for various reasons, physician inertia, meaning we're lazy. There's only so much energy we want to devote to a problem that doesn't seem to resolve quickly. And then polypharmacy. So how many of you who are on antihypertensive medications take more than one? Okay, that's pretty common. And there are many people who are on as many as 5 or 6. Okay, well, so for those of you who are raising your hands to the 5 and 6, as you probably understand, there are first-line drugs. Those are the common ones that have good risk-reward. So a first-line drug would be a drug that has relatively few side effects and makes a reasonably good impact. Most of those are well tolerated. They are usually what your doctor will select first for you to control your blood pressure. In the event that blood pressure control is less than optimal, people will end up on second or third line drugs. What do we mean by that? Second and third line drugs are perhaps more effective, sometimes yes and sometimes no, but always have more secondary side effects, many of which are unpalatable. People don't like to take them. My clonidine makes me very fatigued with a dry mouth. I can't get through the day. It's effective. It works fine. My hydralazine is another second or third line drug. It is effective, but withdrawal from the drug, if you miss a dose or two, you might die. Well, that's not something you really want to be taking either if you can avoid it. And I don't mean to be melodramatic, but that's the dimension of the side effects that you may see and what people would like to try if they can to avoid. Just a depiction of the heart and how many pills. Somebody who raised their hand, about 6 pills or something like that? 5. So that's an example of, you can take a steady diet of that. You don't need to eat any food. There's enough calories in that. Okay, so what is renal denervation? First of all, let me speak to hypertension in general. There are a number of different causes for hypertension. Most of them are what we would fall into the category of essential hypertension or primary hypertension. That means that we really don't have a clue. People have high blood pressure without an obvious other cause. Then there are some causes of hypertension, people who have a blockage in a kidney artery, which is infrequent but important, and maybe 5% of people who have challenges with hypertension will have a blockage like that. That blockage limits the blood flow that the kidney sees from the aorta, tricking the kidney, if you will, to say, oh, the blood pressure is too low. So the kidney then elaborates more hormones because it's thinking that the body's blood pressure is too low. And of course, that's a maladaptive response. That's not what it should be doing, but that is what this blockage convinces it is right to do. And so as a consequence, what we do with those patients, who are, again, few and far between, we open up the blockage with a balloon and a stent, much as we do with heart stents or any other stent in any other area of the body, and restore blood flow, which improves kidney function and improves blood pressure control. So we do that, and those people would not be a candidate for what we're going to be talking about today. Then there's another subgroup of patients, even more infrequent and rare, who have hormonal producing tumors, something called a pheochromocytoma. Have you ever heard of that? Probably not. It's uncommon enough that you wouldn't. A pheochromocytoma is a hormone producing tumor that produces adrenaline-like substances that drive the blood pressure up. So if somebody has such a thing, we obviously want to know about it, and it should be removed. It's not a malignant tumor, but it's a malignant tumor in the way in which it behaves. So it's benign, but it behaves badly because it has consequences to the rest of the body. And there are ways to screen for that with urine tests and blood tests. So having said that, that's kind of the dimension of what hypertension is. Most of it is essential hypertension, which I assume is what most of you have, which doesn't have obvious explanation for cause. There's nothing that we can directly treat. We treat the footprints, not the feet, if you will. So what renal denervation does, and applies to everything other than those two unique things that I'd mentioned, renal artery stenosis and the pheochromocytoma, what renal artery denervation does is it operates by disrupting the sympathetic nerves, which I depicted in that first slide, which run along the kidney artery. If you disrupt those nerves, sympathetic read adrenaline-like. By ablating those nerves, you reduce adrenaline activity in the body, which feeds both the brain and the kidney in a feedback loop. And by disrupting that, you can control blood pressure better. I'm not going to suggest by any means that the procedure that we're going to be talking about today will eliminate blood pressure problems or will eliminate the need for any and all medication, but it certainly can limit the amount of medication one takes. And in some rare circumstances, people go without medication altogether. It's not common, but they do. So there are various methodologies that have been tried in terms of renal denervation. The perivascular injection of neurotoxic agents sounds a little bit medieval, if you will, and that is not what we're going to be talking about. But ultrasound and radiofrequency ablation are the two technologies that are being used for renal denervation. The initial trials were not very favorable. So originally, a company that was using radiofrequency ablation, which is a burst of radiation energy through the kidney artery to destroy to some extent, of the renal nerves. And those trials were initially a little bit challenging. Some had good results, some had less than good results. That group of trials would be called the Simplicity trial. It was first reported in 2014, which means that they recruited for the 3 years prior. So this has been around, as I say, for more than 10 years. Subsequent trials were actually more promising, with more durable results, and done with ambulatory monitoring. So of course, although we don't do it very frequently, we can monitor people's blood pressures either remotely or in real time with an ambulatory device, much as we might do what we call a Holter monitor, which is an ambulatory EKG, which you carry around with you and reports your blood pressures throughout. So there are methodologies, and the methodologies have improved, and as they have improved, we've understood that this is more effective than we originally thought it to have been. So the system that we are using is this system. It's called the Paradise system. We have 2 reps from the company in the back there. We appreciate their being here, and they can perhaps answer some of the questions that I may not be able to. But the device consists of a generator, which you see in the middle, and a catheter. So the catheter is inserted into the renal artery, and of course it would be inserted into both of the renal arteries. Most of us have a single renal artery. Some of us have accessory arteries as well. We treat the large renal artery, and we treat it in 3 different locations with a balloon that looks like that. It looks much like a balloon we use for angioplasty in the heart or the legs or wherever it is that we do that, but within the balloon is a cooling system and a sonographic transducer. So it delivers ultrasound energy, and that ultrasound energy is delivered in pulses over about 6 or 7 seconds each time it's used. And we use it 3 times in each location. And once that is done, we have hopefully a result that improves the blood pressure. Any questions about what that technology looks like? So we treat both, right? We treat both arteries. I'm sorry?
Is it done as a groin approach, like a cardiacapnoplasty?
Typically, it's done via the groin, and it's easier to do it as you point out, I think rightly, many cardiac catheterizations are done via the groin, and many are done via the wrist. This could be done either way, but the size of the catheter, it's easier to do it from the groin approach. It's a much shorter distance than that distance.
When you go in, are you searching for something, or are you just assuming something's there, so you're using energy in several different places?
Okay, so that's a great question. The first thing that we're searching for is to make sure that people don't have renal artery stenosis, that narrowing that I'd mentioned, a blockage in the kidney artery. So we don't do this if they have renal artery stenosis. We fix the renal artery stenosis. And then if they still have persistent blood pressure issues, then this could be utilized, okay? And so that's the only thing we're looking for, is to see that we have a clean artery. And then we want to make certain that we have enough space in which to park that balloon. Want to make sure that we have enough space to park that balloon. Usually we do 3 treatments per artery. Sometimes the artery is too short and we only use 2. Everybody's a little bit different. And we size the balloon to the size of the artery.
Do you have a
Well, everything is done the same way it is under a heart catheterization or peripheral angiography conditions. This is done in the cardiac cath lab. You're lying on the X-ray table. There is an X-ray fluoroscopic camera above you, and we take real-time videos of what we're doing, so we know exactly where we are. Sometimes we even use a device, I don't want to confuse you, an ultrasound device to see the size. It's a diagnostic tool, not a treatment tool. Okay. Other questions? It's actually very simple in terms of the procedure itself. It's much simpler than a heart catheterization. I should emphasize it's done on an outpatient basis, so typically people come in the morning and are gone by 2, 3, or 4 o'clock in the afternoon. Yes, sir.
Is contrast media part of the procedure?
Yes, it is. Thank you for asking. Contrast media is a very small part of this procedure. But do we use contrast media? We might use a tiny bit just to make certain that the artery is clean and to make certain that we have the right size balloon chosen. Yes, ma'am.
Do you see immediate results?
I'm sorry?
Do you see immediate results?
Great question. We're gonna get to that. Can you hold off on that? And remind me if I don't address it, you ask it again, okay? So this is the way the process works. I wish that this would display, but it doesn't. So in red, you see the aorta and the kidney artery. And then in yellow, you see the renal nerves, which run along the aorta and then down the kidney artery to the kidney. And they basically connect the brain and the kidney together. If you look, this is a better image of it, but the density of the renal nerves differs from the early part of the artery out as it goes distally, as it goes more distally. And so you can see in the proximal artery the density of the nerves, in the middle portion of the artery, and in the distal portion of the artery. So hence we want to cover that whole territory as best we can. And the balloon will do that depending upon what the length of the renal artery is. So we have to choose wisely, and that's when we use the contrast. So because this generates a lot of heat, this ultrasonic energy is very hot, there is an internal cooling cycle. So as the device delivers the energy, it immediately thereafter, once it's finished delivering the energy, it cools. This part of the procedure is the unpleasant part of the procedure. So that unpleasantness will occur for about 6 or 7 seconds each time we deliver the energy. If you add it up, that means that you're probably going to have 20 or 30 seconds worth of discomfort during the procedure, although not continuously. It's in pieces, separated by a few minutes each. So there is a period of time during which you're uncomfortable. Patients are pre-medicated for that. We don't use general anesthesia. We use sedation and twilight anesthesia, if you're familiar with that. It's effective, but people will still feel it. So I don't want to mislead you. It's not painless. There is some exposure there. This basically is giving you the idea that there are more renal arteries proximal than there are distal, and you kind of get that sense of where we're going to destroy the nerves. And we don't destroy all of them, we destroy some of them. Maybe damage is better terminology. So these are things that you probably don't need to see, but these are some of the studies, the Simplicity trial, the Spiral trial, the Radiance trial. These are some of the studies that have been done, and in blue is the reduction associated with renal denervation, and in gray is the placebo group that didn't get the treatment. They had the procedure, but no energy was administered. And you can see that there are variable improvements. What you're generally seeing is somewhere between 10 and 15 millimeters of a systolic blood pressure fall. Over time, that may actually grow. So these numbers, I think a lot of this data is early data, and we're seeing as it has crept into our toolbox, we're seeing more durable results over time. And there are some people who are reporting 8-year outcomes with sustained improvement. Your question earlier about do you see the immediate outcome of a blood pressure fall, you do with renal artery stenosis. So when we have a blockage that we overcome, you'll see that within 5 hours. Those patients will have a blood pressure that plummets, sometimes too low, and then comes back. With this procedure, it may take 4 to 8 weeks before you see the measured blood pressure response, but it continues to improve over time typically. So you get your maximal response later, not earlier. Okay?
Is that because during the procedure, there's a degree of, let's say, inflammation that's occurring, and as it decreases, everything opens up a little bit more?
I'm not sure that I know the explanation for that. I can imagine some explanations for it. So if we're damaging some of the kidney nerves, I would imagine that some of those nerves don't die right away. Some of them recover. You reach a steady state over time, so it takes a little while for that to occur. And basically, the brain needs to be retrained. So this is, again, the communication pathway between the brain and the kidney that we're disrupting. It takes a little while for people's bodies to acclimate to it. I don't know a better way to describe it, but that's probably as good as I can get. So again, more studies with more robust results. So here you're seeing 25 millimeter drops and 21 millimeter drops. So again, I think that the early studies said 9 to 15, and people were somewhat nonplussed. But now that we're seeing drops that are as much as 30 millimeters and sustained, people are getting a little bit more excited, which is why the FDA approved both of these devices. So what happens here is that the blood pressure, as you probably know, those of you who are troubled by high blood pressure, you know that if you take your blood pressure in the morning, afternoon, and evening, it's different at each time. Part of that is related to the variability in terms of the dose response of the medications that you're taking. Some of them have a flat plateau effect. Some of them have peaks and valleys. Most of them do. And it depends when you're checking your blood pressure. So if you're in the midst of a valley, your blood pressure is going to be higher because the valley is the dose of drug. If you're at a peak, your blood pressure might be lower. Then there's also variability on our own, even without medication. We each have diurnal variations. So at night, your blood pressures are typically lower. In the morning, they're typically higher. REM sleep will make them higher. There's all kinds of variability that all of us have. And you can see that very well demonstrated in these ambulatory recordings that we take. But what we rely on are doctor's office blood pressure measurements. Why do we rely on that? Because those of you who check your blood pressures frequently, I'm sure know that blood pressure is lower when you take it than when you go to the physician office. Is that true for most of you? Almost invariably so. Which one do we believe? I have patients who argue vehemently, my blood pressure is much lower at home, this is much too high, this is not representative of me. Well, so that might very well be true. But try to think of the way the literature came about. How do we know that high blood pressure is a problem? Is it based on home blood pressures? Of course not. It's based upon studies in medical environments. So it's those blood pressures that matter. It's not to say that white coat syndrome doesn't exist. Of course it does, but that's where the data comes from. So if we say our ideal blood pressure is 120 over 80, for instance, that doesn't come from you reporting your home blood pressures, which include blood pressures of 90 systolic. That comes from office blood pressures. And it's those blood pressures that matter only because that's where the data comes from. So if your doctor should tell you, that's nice, I'm glad your blood pressures at home are meticulously taken and are low, but here they're invariably high, cut them some slack. They're trying to do the right thing. Okay, so this impacts blood pressure 24/7. So you get a flat blood pressure impact. It's particularly valuable in the people who have nocturnal or early morning high blood pressure. And there are some unique phenotypes which have higher stroke and heart attack risk. I think we know that. That's why this is a problem. In the Medtronic, that's the other registry, that's the radio frequency tool. In the Medtronic registry, they had about 3,000 patients. They had 36-month follow-up, and you see what happened to blood pressure drops. The results are much better in people whose blood pressures at the outset are higher, and the follow-up blood pressures are sustained. Approval, as I'd said, was November of 2023 for both of these two devices, the Simplicity study and the Simplicity device and the Paradise device. We use the Paradise device, which I had shown you before. Very honestly, and I'm not saying this because the ladies are here to represent the company, but we chose the Paradise device having looked at Simplicity, the Medtronic device, and which I'd worked with years back, because it's much easier to use. It's much quicker, it's much simpler, and since there's no difference in results in the little data that we do have, and that we only have little comparative data, but since there's very little difference, and one is much easier to use, and one is much quicker to use, the procedure time is half, maybe less, from one than the other, we chose to go with the Paradise system, also because they gave us a very favorable arrangement and allowed us to be in the forefront of all of this. So reimbursement, you may ask, well, is this covered? It is completely covered on an outpatient basis by Medicare. If you have Medicare Advantage, meaning a commercial partner, we have to go through a prior authorization process, just as we do with so many things. If you have purely commercial insurance, you have to go through a prior authorization process. Some companies are more generous about this than others. If you're on Medicaid at the present time, it won't be covered. Maybe by the end of the year, that since this is all new and all evolving, all these rules just changed January 1st, I am anticipating that they will continue to change. So again, how does this work? We talked about this, the overactivity of the sympathetic nervous system, including the kidney nerves, the brain-to-kidney relationship, which increases hormonal hormonal dump, if you will, into the body, which raises blood pressure, which raises urinary sodium retention and leads to constriction of the kidney arteries. So there's an efferent and an afferent pathway. Both are operative and both are impacted by this. Overall, total body renal sympathetic activity is reduced. These are hormones. Renin is a hormone, angiotensin and aldosterone. Those are all hormones that we know that raise blood pressure. Many of you are on drugs that antagonize those. So anybody who is on an ACE inhibitor like lisinopril or its cousins, or an angiotensin receptor blocker like losartan or its cousins, or spironolactone or its cousins, those are all drugs that antagonize the blood pressure issue. And you have increased sodium and water excretion, you have increased renal blood flow by reducing that vasoconstriction, the clamping down of kidney arteries, and you reduce vascular tone. So they're not quite as stiff. The blood vessels are not as stiff as they once otherwise were. Again, I want to emphasize the durable success. Some people have even extended the benefits to sleep apnea, hypertrophy of the heart, which often accompanies high blood pressure, leaking of albumin. This procedure has no impact on kidney function because we use, as you asked earlier about how much contrast we use, very, very little. So we don't damage the kidney during this. It doesn't have the overall impact bodily on adrenaline, which we talk about as the fight or flight response. So it doesn't impact that. The point that I was trying to make there, blood pressure teleologically, if you think about it, what happens with us when blood pressure is low, the body clamps down by releasing a lot of adrenaline and vasoconstriction. And that worked great in an era when our greatest potential cause of loss of life might have been a saber-toothed tiger biting off your leg, right? You're hemorrhaging to death. It releases vasoconstrictor elements to cut off the blood flow as best it can or to limit the blood loss. That's maladaptive today, right? We don't usually die by a saber-toothed tiger bite. We're usually dying because we live much longer and the blood pressure is too high and the blood vessels suffer as a consequence and ultimately they break. So this doesn't impact that at all. So guidelines. We in medicine try to follow guidelines. Sometimes it takes a while for different procedures to enter into the guidelines. To be in the guidelines, you have to prove efficacy in a sustained, meaningful way, and we have different levels by which we measure that. So there's level 1, level 2, category A, category B under each of them, and then there are things like category 3, which would be procedures that probably don't have much merit. So this has entered the guidelines of the European Society of Hypertension. It has entered the guidelines of the National Kidney Foundation. Of course, as I said, Medicare already approves it. SCAI is the Society for Cardiac Angiography and Intervention. That's the union, if you will, to which I belong, which is the people who are proceduralists doing these procedures. And I want to emphasize, look how broad this indication is. So I'll read it along with you. Primary candidates are those with resistant hypertension, blood pressure greater than 130/80. How many of you have blood pressure higher than 130/80? Most of us do at one moment in the day anyway. Taking 3 or more medications, who do not wish to take more medication or don't like their medication, after shared decision-making, meaning after a conversation. This applies so broadly, it's almost inconceivable that it's so broad, right? Because so many of us are not taking 1, many of us are taking 3, many of us are taking more, and many of us don't like the side effects of the medications that we take, because for many of us, they are onerous. Do patients like this? The patients that I have personally performed this procedure in, I can honestly say love it. Why do they love it? Because with rare exception, there was one fellow that I think I'd mentioned to you ladies that had a bad response, but he was in the office recently and he said, no, it's the best thing that I've ever done in my life. So he temporarily didn't love the procedure, and I won't get into why. It had nothing to do with the procedure itself. But many patients are non-adherent. I missed my medicine. I forgot to take my second dose in the evening. I don't like the medicine. I skip it whenever I can. I take half of what the doctor told me. It's too expensive. I don't like to take it. So if you use non-adherence, which is pretty common, they know that their blood pressures are not going to be optimized. And that decision is obviously a decision that they are making, recognizing that there's risk to missing the medication. So if they're non-adherent, they know that they're being non-adherent. They know that that's not good. They're playing Russian roulette, hoping that the problems subsequent to the hypertension are going to not hit them. I'm not going to be hit by that bullet. It's going to be somebody else. Okay. And I think that's it. That's all I had to share of the science of it. I'm happy to try to address questions, but I think what's most interesting about this is that it applies to everybody. It's a simple procedure. Its indications are broad, and it's very well tolerated. Again, the only downside, and I'm being truthful about that, is that there is a brief moment when you're going to say, oh, during the procedure. And if we did it with general anesthesia, which most people do not do, you wouldn't be able to say that either. But it just doesn't seem necessary to use general anesthesia for a cumulative total of 20 or 30 seconds worth of pain divided into, 4 or 5 different segments. So I just think that that's probably worth tolerating. The effects are durable. Of the approximately 20 patients that we've done, we have had, I was going to say one person maybe not a success, but now I think he is a success. So all 20 of them are delighted with what they've had done. And I'll stop there. Yes, sir.
What do you say? It's just uncomfortable or painful?
Or just pain? Everybody experiences pain differently. So it's hard for me to say. I think they don't talk about it 5 minutes after the procedure is done, so it couldn't have been that bad.
Okay.
But I'm standing at their side when they're saying it, and I don't like hearing it. Yes, sir.
How long do these devices last in your lifetime, like to do that?
So that's the right question, which I tried to address earlier, but best answer I can give you now is that there are some studies that go out 8 years and show durable response. But remember, it's only been done for about 10, so we don't, and rarely, mostly in an experimental environment. So I can't really say that I know the answer to that, but let's say for the moment, everybody agrees that it's durable. How durable? Don't know yet. Somebody over here had a question? Yes, sir.
Is there any possibility of it going too low, the blood pressure?
I can't even imagine that problem. So I think the answer is no. I think. It's a good question.
Her problem is that at times, it's way high, and at times it's way low.
Exactly what we were addressing. Thank you for raising that issue, because for most of us, blood pressure is variable. First of all, we have our own variability in our own body with no medication. And then you throw the medication in, some of which has a peak duration of action of 6 hours, some of which has 10 hours, some has 20 hours. So you get all this variability in the effect of the blood pressure lowering medication on top of the variability in the patient's own blood pressure alone. Hence, that makes it challenging. So what I was trying to point out is that this is kind of a great equalizer. Yes, sir.
Are there any medications or conditions that would preclude you having this procedure?
Just as I'd mentioned, if you have renal artery stenosis, that narrowing of the blockage in the artery to the kidney, that would exclude you from that procedure, and we screen everybody for that. Or if you have one of those hormone-producing tumors, the pheochromocytoma, that would exclude you from this. Everybody else is in the mix, which is 99.5% of people. Yes, ma'am.
I hate to be this, I've been bothering you with the whole thing.
It's okay.
But you had mentioned Medicare pays 100%? I thought Medicare usually paid 80%.
No, I hope I didn't say Medicare pays 100%. Medicare covers it. Okay, so if you have any procedure with Medicare, you know that it's typically 20% copay, 80% yours.
I just want to verify.
Yeah, no, it's not. This is not the only procedure for which Medicare covers 100%. It covers like everything else, but it covers it, is my point. Yes, sir.
As a follow-up to this gentleman's question, what if you're on beta blockade and alpha blockade for various reasons?
Okay, that's an excellent question. So there you are dealing with the patients who are on, for those of you who are unfamiliar with that, a beta blocker might be a drug commonly, metoprolol would be a common one, and an alpha blocker would be something like clonidine, which is an unpleasant drug. No issue there. The procedure is done, and then hopefully you'll come off of it, certainly off of the clonidine, which most people love to hate. So, yes, ma'am.
Could you just clarify that there's nothing left in the body? I get the.
Okay, yeah, that's a good point. For those of you for whom I didn't make that clear, this balloon with the devices inside it goes in for the procedure, comes out at the end. It's not like what we were talking about when we have a renal artery narrowing and we put in a stent. The stent is left in. Nothing's left behind here. Thank you for making sure that that's clarified. That's Sarah, who is my office nurse, who handles most of the issues related to this. Yes, please.
If someone were already stented, would that then preclude going in, or would you choose a different?
Fantastic question, and we have done people who have had renal artery stents and whose blood pressures remain high. Yes, ma'am.
This is done under local anesthesia?
Twilight anesthesia, if you're familiar with that, like what you would have for a colonoscopy, for instance, that's familiar to most people. So you're sedated, but you are rousable if we want you to be, and we give you local anesthetic as well at the site. I don't want to overemphasize the pain piece. It really is like a pimple on the butt of the elephant. But I do want to be honest and forthright and say it does happen. You've all asked excellent questions. If you have more that I haven't addressed and you think of them, please ask them. The ladies from RECOR are here with us, graciously joining us to answer questions about billing that I can't answer, because that isn't something that I do. We do have an email site that I believe, if I'm not mistaken, is Renal Denervation at all one word at froedtertsouth.com. So those of you who want to communicate with questions about it or want to ask about scheduling a visit to discuss. Sarah, is that correct? Well, yes, please.
So there's brochures up front here. It looks like many of you have taken them. Great resource. Go online, take a look at it. And also there's an orange sticker. This is the hotline that we've dedicated to have nurses who are fully trained. You can talk to a live nurse if you have any additional questions. They will answer them for you. So please take advantage of that resource if you're interested.
We're really very excited about this. What's nice about this is it's applicable to an enormous part of our adult population. You know, we tout all these exciting technologies that we are bringing to bear that apply to a small number of patients, people who have atrial fibrillation, aortic stenosis, those kinds of things are new procedures that we're very excited about, but they apply to maybe 3 to 5% of the population. This might apply to as many as 50% of the population, depending upon how they want to see this. So it's a new, exciting, upcoming thing. I'm told that at last week's meeting of the American College of Cardiology, it was a very, very hot topic. I'm sorry I missed it. Thank you for your attention, folks.